All right, so I'm going to talk about osteopathic medicine and the challenge that we have going forward. You know, you all started 131 years ago, and I know you're celebrating your 125th anniversary. Y'all are a young society. That's not very old. And look at the advances that you've made at this point in time. I wanted to do an interactive kind of presentation, but the software won't allow for this, but we're gonna deal with that, okay? Even though you're only 131 years old, your missional philosophy hasn't changed, okay? When you think about your mission is unity of the body. That's very cool. I was trained in Western medicine. I have an Eastern medicine background also, though. Unity of the body is so important. Just because we don't understand it doesn't mean it doesn't work. So, this advances that, but it doesn't advance my computer. Good. All right, I need feedback from you all. What has been the greatest driver of change? I see all different generations here in your practice of medicine. I know you graduated from medical school and then you decided you go into medicine. Some of you are employed. Some of you still model the only doctor in a town of 60,000, and you face those challenges. Anybody want to say what's been going on? Okay, well, we're going to reflect. I always like looking in the past. So when I look in the past, I heard insurance. You're right. You're absolutely right. Okay, so how did insurance come to play? In the 40s, it was in the 40s that President Truman proposed health care for seniors, what we know as Medicare. 20 years later, Lyndon B. Johnson signed that into law. You're not that old, Dr. Ely. It's crazy. It's just crazy. But it took 20 years later for that to become law. Since then, a lot of other things have changed. Commercial payers. Somebody mentioned insurance. Well, insurance company, when they started covering for the cost of medication, what happened? We got another layer of administrative complexity called pharmacy benefit managers, right? Just to contain costs. They're not interested in making people well. They're interested in dividends and containing costs. And that's where we have a difference of opinion. So beyond insurance companies, then in '69, you all still fight for legitimate equivalency, okay? The American Medical Association admitted osteopaths initially in '69 and continue the fight, okay? I know still when you look for residency slots, you're wondering, do I compete on a level field? Well, you do, okay? I think we're just starting to realize that. I trained with the DO many, many years ago, 35 years ago in Chicago. We had the best time at Cook County Hospital at 3 in the morning usually, but they were great. Okay, in '73, HMOs disrupted. '73 was pivotal year, okay? Up until that time, we didn't have all these other factors pressing down upon us on managing care. But when the HMO model came into play, corporatization of medicine became a reality. Going on from there, Hillary Clinton developed HIPAA, the Health Information Portability Accountability Act. That was to protect patient health information. You'll see how unintended consequences of what we try to do play out in the future. The consequence of the HIPAA was more administrative work and complexity in sharing patient information. Now, because of HIPAA, I have to pay my IT person annually a sum so he can do a security check on my computer or my computer systems. That's ridiculous. That's just utterly ridiculous. All right, so after that, we had the Gulf War syndrome, and then with the Gulf War syndrome came funding for research. Now the government allocates approximately $300 million for more research for Gulf War syndrome annually. When AIDS came around, we increased the power, interesting word, but that we increased the power of the CDC in the space of public health. It's great getting old. I have like 5 different focal distances. Human Genome Project came into play in 2003, and that has opened up an entirely new way that we have clinical tools to address illnesses. The American Academy of Pediatrics just recently deliberated over whether or not it should be mandated that we do genome sequencing on every child. Interesting ethical problem. So the Affordable Care Act, which was in 2010, generated pushbacks. It was Obamacare. It presented pushbacks from commercial payers. So the insurance industry needed to contain costs, and they decided that they would create narrow networks. You all know what narrow networks are, right? If you don't have a contractual relationship with the Blues will kick you off. Well, what happens to your patients who are Blues? I mean, Blues, let's see, it's the S plan that does the state employees in the state of Tennessee, and some of them can't go to one of my hospitals because they don't have a contractual relationship. What does that bring on? That brings on the problem of surprise billing. Every time a legislator says to me, surprise billing problem, I said, no, it's not my problem. I said, do you know who created it? I said, I won't go as far back as to say the government created it, but it's the insurance companies. They created narrow networks. The narrow networks created surprise billing. It's just a domino effect, and people need to be educated about that. Okay, so 2022, which is not on that slide, is the Cures Act. What happened with the Cures Act? The Cures Act was to promote patient health information interoperability. The Cures Act, which the ONC took over, said that if we do not share patient health information in a facile manner, we are blocking it. Well, we're blocking it because of HIPAA. So on one hand, you have the government saying we have to protect patient health information, and on the other hand, they want us to make it interoperable. So I'm just saying be careful and point this out to legislators that they just have to be really careful about the unintended consequences that come out. So once somebody said insurance companies, I would agree. I would say that that's a primary driver of change in how I practice medicine going forward. So when you consider all the external forces, is it still worth it? Are we still heroes? I don't know. Is it our responsibility to be a champion of medicine? Is that why we went into it? And then the question is if that's why we went into it, do we have the tools to do our job? Well, I do believe the public needs champions. I do believe that we are healthcare leaders. I do believe that we need to advocate for our patients. I do believe we need to maximize our numbers because we have a manpower issue. We also are redefining ourselves as physicians. You all are physicians. We need information technology reform. And I do believe that as Sir William Osler, who's one of my champions, never met him. I am too young for that. But he defined our profession as noble, and I do believe it's noble. I mean, it's not Pollyannish. I do believe it's noble. Okay, so as colleagues, we start out by being champions for medicine by being collegial. We are colleagues, okay? We are colleagues who support each other. We work together. It doesn't matter what your specialty is or what from school you graduated from or which hospital system is your primary base of practice. We're colleagues. Criticizing other doctors just doesn't help. I go in the OR, I go in the physician lounges, I work at 4 different hospitals, and I listen to a multitude of different kinds of providers. The point is when we criticize each other for the crazy consult that came in at 3 in the morning, or the fact that I can't get a specialist down to the ER because, oh, they never answer my consults, okay? It's gonna take hours. If you say that in front of the patient, all it does is give them fuel. If you say that in front of any network employee, the network is always out there. They're everywhere. And all it does is give them fuel to divide us and cast disparaging comments on our profession of healing individuals. Our profession is competitive. You all competed for training slots, right? You competed for residency clinical spots. It's very competitive, but competition's over. One of my favorite stories about how competitive we are is when my hospital went go live on a new EHR system. We had 2 nurse practitioners sitting in the training room on one side, and we had 2 MDs sitting on the other side, right? You can see this. I'm sure you've been through, doctor has to go for 5 hours of training on a new EHR. Okay, so in that, 4 different patient scenario cases were given to the trainees. The nurse practitioners blew through them, okay? They were comparing notes. They were telling each other the shortcuts on the EHR. The 2 doctors sitting on this side, plowing through it as individuals. No communication between them, like, how'd you do that? Show me how you did that. So I think it's time for the competition to be over. I think it's really good for us to learn how to say, I don't know how to do that. I need help. I think that's a really good thing. Okay, I recall also another sign where the hospital was supporting each other when a patient came to me and started complaining about another doctor. And I looked at them and I said, I don't affirm their conclusion. That doesn't do anything. But instead of that, I just look at them and I say, you know, doctors have a really tough time doing what we need to do because of blah, blah, blah. And that, their eyes just like go wide open, and they don't realize how hard it is that we struggle just to make them better. And that's all we want to do. We just want to make them better. All right, so I think it's time to praise and encourage each other no matter what. I like the idea of unity of the body. You practice unity of the human body. I think it's time to have unity of the medical professions also. So as healthcare leaders, you are team leaders. Now, I know that the Collaborative Care Coalition members are here. Dr. Bell is here, and Dr. Whiting is here, and they have been leading TOMA. Okay, you all, thank you very much, have been a leading voice in the Coalition for Collaborative Care. It was in 2012 that I mentioned to the TMA, guys, we're fighting this all alone. We need to have one single message. We need to have one single voice on the General Assembly in the state. And they said, yes, we do. So we need to convene a group of physicians. And so we did this. It created one voice. It created one voice with one message. What is that message? That message is the best model for healthcare is patient-centered, physician-led, team-based healthcare. Physicians are leading this care model. You all are the best equipped. Now, can leaders be trained, or are they born? I think leaders can be trained. I have plenty of physicians, younger ones, who say, I can't do that. And I go, the heck you can. You can do that. It's easy. You just do this. So I do believe that you can train leaders. And I went backwards, didn't I? I apologize. Okay. Leaders are the first to arrive. You're the last to leave. You are the moral compass. It's work. Sorry, there's no way to get around it, okay? If we want to be leaders of healthcare, we're going to be the hardest working ones there. Of course, we're not remunerated for it, but that's just the way it is. At the end of the day, the people that you want on your healthcare team are the people who share your vision and that your moral compass points to what is best for the patient. I think that our abdication over leadership has led to our loss of control. I feel like I'm preaching to the choir here, because I think, and this is just a reflection, but amongst all the different graduates that I have come across, the ones who are most advocating for patient well-being, patient health, and care have been osteopaths. I think a lot of the medical students that I see that are from the traditional, older medical schools have been too busy. I'm too busy. I'm not meeting this expectation, I'm not meeting this. And sure, there's a lot of pressure there. But it is our abdication of leadership in creating pathways for healthcare that has led to our loss of control. So thank you for taking that leadership role. I'll give you an example on the local level. When nurses come to me for, let's say, the director of nursing and says, I can never find anybody to sign the death certificate. It's got to be a physician. That rule has changed recently, but they say, can't find a doctor to sign the death certificate. And I said, okay, well, let's look at the problem. Let's get everybody who is involved in that process at the table. I also like to include members of a patient's family. So I always like to have a patient representative at the table, mostly so they understand the problems that we face as a healthcare team. But we get everybody together and we iron out a process. That process should be physician-led. It doesn't mean you abdicate. It doesn't mean you have to go at 3 in the morning to sign the death certificate. But it means you create that process. You sign off on that process. You're the one who says, this is good for our patients. This is safe for our patients. You can say, okay, we'll let the nurse practitioner on my team, or we'll let the physician assistant on my team, or we'll extend the amount of time that it needs to be signed so it can be 7 o'clock in the morning. Nevertheless, you work out the process, but you lead the process. If you don't lead the process, you're going to have members of the Tennessee Nursing Association, members of the Tennessee Association of Physician Associates, coming to their legislators, and they're going to say, nobody's signing the death certificates. The nurses can't find anybody to sign them. We need independent practice. And that's what's happening. If we're not available, they're going to find somebody to fill the void. I'll give you another example. Recently, I saw on national news somebody talking about some public health issue. I can't recall right this time, but it was the nurse practitioner who was addressing it. That shouldn't be the case. We should be the addressing ones, the public health issues. When the media comes to you and they say, we need a doctor to talk about this talking point, a lot of us, including me, are reluctant to talk because it's scary. You're scared you're going to say the wrong thing. You're scared it's going to fall back on you. Okay, quick and dirty lesson. This is going to take 3 minutes. It's going to make each one of you champions of talking to the media. It's easy. It's easy. It's like playing basketball in the Final Four. So they come and they say, Mrs. Jones, Dr. Jones, what do you think about your position on, we'll take a hot one, abortion? And you're like, oh, great. I have to talk about abortion. I'm a nose picker. I'm an ENT doctor. What am I going to say about abortion? And it's such a hot topic. So I'll look at them. Anytime that they catch you off guard, whenever they'll tell you that they want to talk about a topic. So have your talking points in your head. These are elevator points. They take 2 minutes to spit out, less than 2 minutes. So you've got that rehearsed. But if they ask you a question and you don't know the answer to, and it doesn't seem to resonate anything in your mind, you just look at them and you go, that is a great question. It's complicated. There are pros and cons on every side, but the important point to take home is this. And then you state your point. Done. You can talk to any newscaster on this, okay? So y'all got that? You always, if you don't know the answer to the question, you go, that's a great question. It's complicated. There's no easy answers. But the point to take home is this, okay? So now any news media can call you for a position statement. Leadership is found on so many different levels. It doesn't have to be as the CMO or the CIO or the CWO or any other C-suite physician in your hospital system. It can be in legislature, okay? I know all of you are familiar with being leaders in legislature. I like this because it shows that it's making sausage, because that's what it's like. One of the bills that we worked on was American Academy of Otolaryngology and American Academy of Audiology. The audiologists wanted the privilege to take out wax, and we said, fine, but it's got to be safe. So we looked at their training protocols, and we ironed everything out, and then the sponsor of the bill pulled the bill. And I was like, we spent an entire year working out safety rails for this so we could expand scope for audiologists, and you pull the bill. And I went, great. Okay, not a problem. That's why there's an ear in the background, because I wanted to remind myself to talk about that. The advocacy of one voice goes back to Dr. Bell and Dr. Whiting and anybody else here who has worked on scope of practice. I'm not even going to go into it. All I'm saying is that listen to them when they come and give them money. Give them lots of money, because that's what it takes to influence the legislation. We have a manpower issue. Have you all talked about that as an association, either on the local or the national level? What do I mean by that? Okay, there's a serious manpower issue. Look at that graph. This is not a new graph. This is old. So I hope this is maybe the second or third or fourth time that you've seen this graph. It's pretty clear, right? Physicians are down here. We have flatline growth. So we're fighting a war. It's called scope. And I love studying war, okay? So you're like, when you talk about the English and the French study their war, 100-year war, you have the right flank and the left flank. Well, we've got PAs on the right flank, and we have NPs on the left flank. We're going right down that valley. And there's another problem. There's more soldiers on the right and the left flank, and we don't have very many. So how do we deal with that? It's really important for you to cultivate those relationships with key legislators. Take them out for coffee. Get involved on the same committee as them. If you don't have time for that, get their email. Every legislator sends out an email. Get on the email, read it, send back an email saying, thank you for your service, I like this bill, I don't like this bill. Every legislator looks at 400 plus bills every year. I would say, correct me if I'm wrong, Michael, but I would say when I look at the 400 bills, 70% involve healthcare in some aspect. It could be mental health in the educational system. It could be whether or not we're allowing music therapy. Point is, it's not always in your wheelhouse, but read about it. You have an opinion on it. You all are physicians. You're smart. You're really, really smart. You can take data, you can consolidate data, you can come up with an opinion, and it's usually the right opinion. So you can always feed back to your legislator. Say, you know, that's really interesting bill. This is how it impacts my space in caring for my patients. I had a patient who got better after they learned how to play a C scale. I mean, so many different things, and then always end that communication with, thanks a lot, and hang in there, because it's hard. I could not be a legislator. All right, so, where is it? Manpower. Yes, sir.
That was up to 2012.
Yes.
Has the growth continued to go on sort of the same lines? I mean, we're you know.
Is it plateauing? No.
That's what I was wondering, yeah.
But the GME, the Congress,
Yeah.
you may have seen recently, actually it was last year, Congress allocated for 200 more slots of graduate medical residency slots across the nation. I'm like, 200 across the nation? That's like less than a drop. But that's what they've added. Congress has recognized that we have an access problem to physicians, especially in underserved rural areas, so they allowed for 200 more slots to be funded for. In Tennessee, we're getting one of them, maybe two. Is it two? One. I think it's one or two that we get. The interesting thing about the government is that when they fund slots, they go, we're going to fund for slots, and they don't say how long they're going to fund for. So 3 year, right? About 3 years to train as a resident, and then if you want to do a specialty. So if the government trains for one extra slot for 1 year, who's going to pay the next 2 years? You're like, wait a second, the math doesn't work. So you go back to the drawing board and ask them and say, we need 2 more years. Does that help? But you're right, the slopes are diverging still.
I mean, that's 11 years since 2012, so it's continuing to go
Correct.
the same direction.
Correct. I think the training model also impacts into that. ACGME recently said, well, you know, it's really tough to be a doctor. Takes a lot of smarts, takes a lot of training. Maybe we should add another year. I went, bad idea, really bad idea. Because you're competing with nurse practitioners and PAs who train in yeah, right? Some of them are 1 year online. I have a medical assistant, she's going to be a nurse, she's going to earn $36 per hour when she graduates in 1 year, no clinical time. It's all online, and she's going to hit the floor. Now, I'm not going to say that's bad. I'm just going to say that's the data that's out there. That's what the landscape looks like. Okay, so for us to add another year, I think we have to ask ourselves, is it really necessary? I don't know. Okay, so the other big problem with the manpower issue for us as doctors is the electronic health record. I used to be able to see 20 patients in a clinic. So in the morning I'd see 20, in the afternoon I see 20. I can see 12, maybe now, and it's all because of the electronic health record. And so they need to understand that. I don't know where telemedicine is going to fit in this space, whether or not it's going to help us with access. I'm very excited about it. I'm very excited. I know that there's a primary care doc in Cookeville up on the plateau who uses telemedicine with video capabilities to expand his impact in his community, and so with nurse practitioners and mid-levels. And it works. I like it. Yeah?
Is there a way we can get, EHR has not really worked well, and especially the way it's mandated. Is there a way that can really, physicians and even nurse practitioners stand together and say, hey, this should change?
That is like an excellent question. I love you. Could you come up here, please? The question was, is there a way that all of us as providers, because we are not the only people with burnout. Nurses are burned out, PAs are burned out, NPs are burned out. Can we join together and say we need EHR reform? Yes. And I have asked, the AMA to work with the other national societies to ensure EHR reform. I have been responded that indeed is happening, only to the level of my specialty society banding with the AMA. And they do white papers and collaborative letters where everybody signs on to the letter, but you still need the boots on the ground. But you're absolutely right. So electronic health records, how did this come to be such a mess? Okay, so when Ma Bell, and I'm not old enough, thank goodness, to know this, but when Ma Bell rolled out telephone lines, the government had the wisdom to say, we need a common way of using that tool for communication. When EHRs became something and Obamacare said, we need to mandate electronic health records, or we need to punish those who don't use them, they did not have a common platform for software interoperability. They did not have a set way of collecting the data. So what was the consequence of their wisdom? We have more than 500 software programs, and that's a low estimate. 500, I have to keep it clean, my language, 500 programs out there that don't communicate. And I was just talking about with IT. Every single time I have to execute another order, I have to do 2 different windows I have to open up, double authentication, right? And then if I don't attend to it right that time, they say, Dr. Denneny, somebody's bleeding, you have to go over, and I take care of that, and I come back to my electronic record. About 2 minutes later, it's booted me out. So I have to go through all those authentications again. I'm about to pull my hair out. I go, nope, can't do it. And I actually do that when administration comes to me and says, can you do this? And I go, nope. Which would you rather? Would you rather me save this patient's life, or would you rather me put in the data so your HCAP scores goes up? They want the money! This is crazy. They want the money. It blows my mind. Okay. It's a little scary. Oh, I want to go back to that. Did you see that slide? Go back. Thank you. In the 50s, the amount of time it took for us to double medical information was 50 years. So the amount of stuff that we have to know in the 50s would double in 50 years. It's 73 days now, guys. And with artificial intelligence coming through, man, is it just going to speed along, which is exciting. I mean, it doesn't bother me. I think that's really exciting. It's just a little weird. Okay, so we've got the burnout. We know that more of us are going to retire because of the burnout. Why are we increasing our burnout to each other? This is one thing that really, really bothers me. In this time of everybody confronting everybody else, it seems like for us to turn on each other is a little short-sighted, might I say. For example, when the COVID pandemic broke out and the vaccine became an issue, we had the Federation of State Medical Boards censoring us if we wanted to say anything other than the promulgated message that came out from the government. I'm not saying that's wrong. I'm not saying that's right. I'm just saying that science is not that clear all the time, and we as physicians are charged with discussing this with our patients. The physician-patient relationship is, to me, it is a relationship that should never be violated. It should never be violated by medicine, by the government. It should be never violated by each other, okay? Science, just recently they came, okay, perfect example. When I'm in training, we used to treat facial paralysis one way. 10 years later, we flipped, 180 degrees. We don't do that anymore. So science evolves. It's not that we're wrong. It's that science evolves. We don't know what's going to happen with all our new technology for messenger RNA vaccines. It may be the best thing, it may be the worst thing, but at this time of unknown consequences down the road, we have to remain open. I don't believe in any medical body censoring another physician. That just should not happen. If we go way back in history, do you all remember a guy named Ignaz Semmelweis? Yeah, he was brilliant. He was the father of antisepsis. Well, he said this to his Hungarian colleagues. He said, like, guys, you need to wash your hands. And they went, nope, you're wrong, you're wrong. They didn't even say nope. They cast him out. They had him committed. They had him committed to an asylum. 14 days later, he died. Makes me so angry. Anyway, and they recognized that he was right. So when I think about all our medical boards, I like to work with our medical boards. Yeah, Dr. Miller.
I just wanted to say, working, one of the things you listed is the flipping from private. There was 28, it used to be 80% independent, 20% employed physicians. It's completely the opposite. And, I work in a system, Ascension, and the problem that I see the most with employed physicians is you have the national hope is that maybe technology could be used to our favor. And the one thing that's changed in the last several years is the advancement of AI has really rocketed. And that's a real mixed bag. I know how everybody's concerned about that. But the hope is for the positive side. In fact, next week I'm starting, they've been able to get to the point where I'm going to be testing a virtual scribe. In a sense, I can walk in and talk with the patient, discuss the problems, and when I walk out, they'll use natural language, and my note will already be constructed. And with that, if they can advance it to placing orders and such, we may actually get to a point where we can do what we want to do, which is to go in and use our brains that we studied with and not be clerical workers. So there is some hope in the future. I just want to make sure we said that, because AI may be able to afford us something of a relief from this burnout that we have.
I couldn't agree with you more. No man can serve two masters. Plain and simple. You just can't do it, and you will burn out if your expectations on one hand are this and on another. Yeah.
Expand upon that. I used to work in yard. They wanted you to admit the percentage of so many people that came through. If everybody that came through that night had a hangnail, they still wanted you to admit it. And yet if you admitted something that was not admittable, you were in trouble for admitting a non-paying patient.
Yeah, private equity and their numbers should not be driving what we do for patients, right? I think that we have to keep saying that, okay? And there's going to be a slide, maybe 2 down the road, I can't remember, but it shows that our goals are not aligned. But that's an opportunity. That's an opportunity. We may be saying it until we're blue in the face, but don't stop saying it. I don't stop saying it, and I don't stop saying it in a confrontational manner. I say it in let's find a solution kind of manner and posture, because I think we can find solutions where there's compromise and going forward. I can't wait, Dr. Miller, when it first came out with electronic health records, I said, I want Google glasses. I want, like, Minority Report. I want to be able to touch here and pull down here and touch here and pull down here. I want my own robot to do everything for me so I could just talk to the patient and get them better. Do all that other stuff like executing. My girlfriend the other day had to discharge somebody on lithium. She could not find the pathway to order lithium. She could not write a written prescription. It was very difficult. Okay, so let's see here. Let's go on. All right, so I would be remiss if I just didn't address this really briefly. Violence is on the rise. I was at University of Michigan, and one of my colleagues, this was in '88, and he was shot and killed. It was a patient who was dizzy, chronically dizzy. Lots of, as you know, dizzy goes with mental health. And we didn't have protocols in place to take care of it at the time. So in your own space where you work, just as colleagues, I would ask you, make sure you run your security protocols. Make sure you keep your doors locked if you need to. Make sure you have a protocol in place that all your team knows what to do and how to identify and de-escalate situations where you may be able to identify and prevent something like this happening. Okay, I think I missed one. Yay. So to your point, sir, and I'm sorry, I don't know your name, but to your point, you asked that question, can we band together? You look at all of these issues, and this is a short list of what, these are problems. It's only a problem. Why is it a problem? It's a problem because it stops us from being doctors. We just want to get people better. That's it. If I can solve these problems, I can take care of more people. So with all the limited resources that we have, maybe it's time for us to band together with Tennessee Hospital Association. They do struggle with electronic health records. For one system to go from Epic to, what's the other one? Cerner, $3 billion minimum. So they have cost concerns also. As we were talking, as artificial intelligence becomes implemented, somebody's going to have to make the patch that's going to allow our EHR to become more facile with it, because I don't have the money to do that. So when the Cures Act came around, they said, we're going to protect patient health information, we're going to allow interoperability. When the government decided that they were going to allow interoperability, they created another layer of administration. What was it called? The Office of the National Coordinator, the ONC. The ONC is just my tax dollars going to pay another person to tell me what to do. And that's what they do, okay? The ONC says, if you don't share your patient health information, you can be fined for blocking. Not just me as a practitioner, but also the hospital. $10,000. So I either have a choice. I have a choice to pay $10,000 per provider in my system to update all my software so that it meets all their interoperability, or I can pay $10,000 to the government to slap a fine on me for blocking information. So you're right, we need to correct this. And it will get better. I think, not to be too much of an optimist, it will get better. I think that some of this is our fault to a degree. I think we as physicians always say, oh, I'll take care of that. Oh, I can do that. Oh, is Mrs. Jones going to need that? Oh, I'll work her in. We can't do that. We're enabling. If we see nurse practitioners who are doing the wrong thing, okay, we just cover up for it. We make it better because that's our job. That's how we're trained. But at some point in time, maybe that might not be the best thing to do. Maybe we should say no. Okay? This is very controversial. If you look at a healthcare system, hospitals wouldn't survive. Just like you said, we have to supply the hospital with patients. They won't survive if we're not there. Maybe we should say no. Maybe we should say enough is enough. I mean, should we say no? I don't know. And why would we say no? It's like on American Idol, there's a fly in front of me. Okay. I think we can say no. That's easy. I think the decision of whether or not we should say no is still up in the air. And then I think when people say, why do we say no? That the optics should always be, we're saying no so we can improve patient health. So burnout, we talked about burnout, we talked about private equity invading our space, we talked about employed physician, the flip from 80-20, 20-80, we think about the rising cost of care. We did think that Congress is hearing us with the implementation of expansion of 200 graduate medical education slots. We became doctors to cure people. The corporatization of medicine, which has happened since the implementation of HCAs, has created two divergent paths. The goals are not aligned. One goal is to make money, and other goal, which is ours, is to cure patients. For example, Chris just did that OMT presentation. That was great. I loved that, okay? I believe we had a whole, last night in our community, we had a huge discussion about gun violence. And I was sharing with Betsy that, why do people shoot guns? Why do people have the need to exert or display dominance over something else, or display control over something? Well, I always go back to when we're 5 years old. Why does somebody bully somebody at kindergarten in the playpen? Usually because they're insecure. So from the root of insecurity comes anxiety. If we can cure all the anxiety in the world, we don't have to have all this gun control. Excuse me. So if we can cure anxiety with non-pharmaceutical methods like OMT, that's great. We live in a society that wants a pill for everything. There's a problem with that, okay? We use 90% of the world's pharmaceutical market. Americans just take too many pills. That's simplest statement. We take too many pills. And so if we can think about non-pharmaceutical methods, I think we should. Why do we not do that? Because y'all don't get paid for it, right? Your model, you don't have time to do what you need to do for a patient because you'll go bankrupt. You don't get paid for doing OMT like you should get paid. Maybe you get paid 2 cents, right? 3 cents? All right.
What about unionization?
Whoa, guess what? Did you look at my slides? Because that's what I'm going to talk about. So, is it unprofessional to say no? We always redefine what professionalism is. We've got the Hippocratic Oath. That's our basic fundamental tenets. You may have a different oath. You may do the Oath of Maimonides. But basically, it's the same thing, and it doesn't change. One of the things that came around when I was practicing 20 years ago, we started wearing scrubs to see patients, right? There was this big brouhaha. You shouldn't be wearing scrubs to see a patient. You should be in your coat and tie and your dress and blah, blah, blah. And I went, you know what? It's not what I'm wearing that makes the difference. It's how I wear it. If I wear anything that doesn't display respect for my patient, it doesn't matter what it is. I said, patients care about being respected. They don't really, I don't think they care about what I'm wearing as long as it's clean, right? So I think that's really important to take home, and it's the same thing with unionization. What is the public going to say if we unionize? Is it time to unionize? Are our professional organizations to be the champions of unionization? Are we supposed to use them and leverage them and exercise them to be the voice of a union? Is it because they're not being the voice of a unionization that they're losing membership? These are all really, really interesting questions. But I think the bottom line when we argue about all of it, which is really exciting, is one, residents. I think the last one was 33% of residents are unionized. Medical students are thinking about unionization. I think when we unionize, the same thing as when we advocate for anything for us, I think the point is that the message goes out that we're unionizing because we want to treat patients better. It's for the patients that we unionize. It's not for ourselves. If it becomes a self-serving thing or viewed as a self-serving thing, I think that can be very divisive. It could be hard. So, if our compass needle always points to best patient care and placing their needs first, taking care of them, nope, I got it wrong, sorry. Taking care of us helps us to take care of them. I think our goals are aligned. So, to whoever asks, is it time to unionize? I don't know, but I think taking care of us helps us take care of them, and I think that has to be driven home. The amount of busy work that we do is just crazy. We need to join together to create reform on that point. I think they are going to join forces to drive EHR reform. The most important point when we drive EHR reform is we give the government a solution. If we don't give the government a solution on reform, who's going to pay for the reform? Me. I don't have the money. They're going to say, you have to do this for your patients because we need reform, but you're going to pay for it. We are the only profession in this time of double-digit inflation that has not gotten a cost of living raise. Okay? People need to recognize that. My margin for paying my employees is shrinking, and we're a family. I'm going to give my employees a cost of living raise, no matter what, even if I don't take home as much, because we're a family. They earned it. We juggle too much. We juggle way too much. We have too many responsibilities. Saying no does not have to be obstreperous. It doesn't have to be fractious. It doesn't have to be divisive. Saying no is an opportunity to come together and find solutions. Saying no is an opportunity for us to direct healthcare, to lead healthcare for the future. going back to my friend, Sir William Osler, we go back to a profession where we inspect, we percuss, we palpate, and we auscultate. And then we synthesize it all together, maybe with the assistance of artificial intelligence. But the point is that after using all those tools, it's our brains, we use it to help one individual, which is just so cool. I love doing that. So you are champions of osteopathy. You are champions of medicine. You matter. You help people every single day. So thank you for doing the work. And I hope you have a great weekend. Thanks.